Welcome to Mingwan Pija. My name is Benjamin, and today I'm going to be talking about intestinal obstruction. So intestinal obstruction is going to be mechanical or the non-mechanical blockade or intestinal contents passed through the bowel, and they're going to be caused by a number of factors. That's going to include those that affect the small bowel, those that affect the large bowel. So we're going to approach these causes or the etiologies of intestinal obstruction as those that are within the lumen, the intraluminal, those that are within the wall of the bowel, which are the intramural, and those that are outside the wall of the bowel, which we can call the extraluminal. So the intraluminal causes more those of the small bowel and the large bowel. So the small bowel, it can be the brow stones, it can be ascaration buccaries, and these are the round ones. It can be foreign bodies, it can be bezoars, and it can be meconian areas, and that is seeming units. Then when we look at the large bowel, the factors that are inside the lumen of the large bowel that cause obstruction can include fecal impaction and foreign bodies, as well as bezoars. And sometimes it can be inspissated by a barium. This is very rare. Then we have the intramural causes. When it comes to intramural causes, these are the ones that affect the wall of the bowel. And for the small bowel, it can be a disease like Crohn's disease. It can be congenital atresia or stenosis. It can be intestinal tuberculosis. It can be radiation enteritis, as well as other neoplasms. Then the large bowel the wall of the large bowel can also be affected, and that can be seen in carcinoma of the colon. It can be diverticulitis with fibrosis. It can be inflammatory bowel disease still. It can be ischemic colitis with strictures, and it can also be volvulus. Then when we go to the extraluminal causes, the ones that affect the small bowel can include the adhesions. This can be postoperative, it can be hernia, it can be volvulus, intussusception, as well as external compression by other tumors or abscesses. Then the large bowel, the causes of obstruction that are outside the bowel can be carcinoma of the colon with external invasion. It can be sigmoid or volvulus, and this is when there is pasting of the large bowel. Can be adhesions, it can be hernias, as well as other extrinsic tumors too. So when we go to the pathophysiology, what happens? What happens is that you are going to have more accumulation of gas and fluids. And in this occurs, we are going to have the distension, because if we have this obstruction, above this obstruction, there's going to be accumulation of gas and fluids. This is going to include the intestinal juices that are produced, as well as the gas that is swallowed. And this is going to increase the lumen in that pressure. And when the lumen in that pressure increases, it's going to compress the veins, and we have venous congestion. This is going to cause mucosal edema. Now, when this happens, we are going to have translocation of bacteria. I mean, this bacteria gets out of the gut and enters into the bloodstream. We are going to have endotoxemia. Then, as this intraluminal pressure continues, it is going to also occlude the arteries. And when the arteries are occluded, we shall have ischemia. As we have ischemia, we're going to have necrosis setting in. And once we have necrosis, operation is going to happen, and then we shall have peritonitis. So whenever we have strangulation, it's an emergency, and strangulation is going to cause a little pain, and this pain is going to be found to be out of proportion to the findings. We shall have fever, we shall have tachycardia, we shall have a leukocytosis, as well as metabolic acidosis. So when we go to the clinical features, we have the symptoms that are going to help us to differentiate clinically the small bowel obstruction from the large bowel obstruction. So when you look at the pain and you have the small bowel obstruction, it's going to be a colicky pain, and it's going to be centrally located. Whereas if it is large bowel obstruction, it is also going to be colicky, but most of the time it's going to be in the lower abdomen. Then we may have vomiting in these individuals. Those who have small bowel obstruction, the vomiting is going to occur early and it's going to be profuse. Whereas those with large bowel, obstruction, they're going to have vomiting setting in later. Then when you look at the distension, the small bowel is going to cause a less distension, and this is because of the profuse vomiting. This is always going to help to expel this fluid and reduce on the distension. But the last bowel where the vomiting is delayed, we're going to have a gross distension. You may have constipation, which can be early in small bowel, but it is going to be absolute when it comes to the large bowel. Then we have visible peristalsis. So when you look at the abdomen, you may actually be seeing peristalsis taking place, and this is more common in small bowel and very rare when it comes to the large bowel. Then in both cases, you can have some signs of dehydration. You can have increased bowel sounds, and this is going to be in the early stages. Later on, the bowel sounds are going to disappear. Then we're going to have shock. If there is strangulation, there is perforation. So we go to the investigations that we do in summer, and we suspect to have IO. We can do a full blood count where we see an increased white blood cell count. We can do electrolytes where sodium will be low and potassium due to the vomiting. We can do urea and creatinine, which are going to increase because of the dehydration, and we shall have concentration. Then we can do the arterial blood tests as well. We can see metabolic alkalosis if or due to the vomiting, or if we see acidosis, then we highly suspect that there is a ischemia and production of lactic acid. Then when we do an abdominal X-ray, we're going to see the dilated bowel loops, and in small bowel obstructions, they are central and they have the valvular condientes visible. Whereas in large bowels, they are going to be peripheral, the loops are going to be peripheral, and they are going to have house markings, which are known to the valvular condientes. Then when you do the X-ray still, we can see multiple air fluid levels, which signify that we have a mechanical obstruction. Sometimes we can see gas in the colon or rectum, and this one will signify complete obstruction. We have other signs like string of bead sign, which means that when you have gas trapped between the valvular condientes, and that is in small bowel obstructions, we have things like the cutoff sign, which is abrupt termination at the site of blockade. Then we have things like the coffee bean sign, volvulus, we have a distension, volvulus, and we have free diagnostic air if we have a perforation going on, as well as in this patient toward IO. Then when you do the CT of the abdomen, and this is the gold standard test, you're going to see a dilated proximal and a collapsed distal loops, and this will tell us that and we shall have also a transition zone. This will tell us that there is, because of the obstruction, the proximal part is going to dilate and the distal is going to collapse. Then we have the transition point, or which can show us the level of the cause. You can have things like required sign in volvulus, sigmoid volvulus would have a peak sign, and then you have the closed loop configuration. And whenever we have a closed loop, this is very important because we can easily have strangulation occurring. Then we have the bowel wall thickening and reduced enhancement, and this occurs when we have ischemia. Then we have pneumatosis intestinalis and portovenous gas, and this is seen when we have infarction. So whenever you see air in the wall of the intestines, that is pneumatosis intestinalis, and air in the portovenous system, you know that we are most likely having infarction. Then we have free air or fluid. This is going to be seen in perforation. We have regular triad, which is seen when you have a patient with gallstone ileus, where someone is going to have pneumonia, an ectopic stone, as well as small bowel obstruction. That is regular triad. Then on CT also, we can be able to see, we can have close to the cause, like in adhesions, we have abrupt change with no mass seen on CT. In hernia, we can have a bowel at the defect of the neck or at the neck of that hand of the defect in the wall. We see bowel there. Then if it's a tumor, we can see a focal mass. If it is in resuscitation, we can see the target sausage. Then if it is in volvulus, we can see the whole sign. So when we do the ultrasound, we're going to find that we have dilated fluid loops, which are greater than 2.5 centimeters. That's going to unify obstruction. We can have 2 and 4 pericells also seen on ultrasound. We can have the target predominant signs in resuscitation. We can have the volvulus sign, volvulus. We can say free fluid and thickened wall if we have strangulation or ischemia. Then we can have collapsed bowel. That is the distal bowel can be collapsed if we have a complete blockage. Then when we do contrast studies where we do a barium follow through or using gastrography, we can have things like delayed passage and the obstruction. We can have contrast reaching the colon, and we can have things like the bird's beak, esophagus, signifying sigmoid volvulus. We can have the glow sign, which is seen in interception. So when we look at the management of these patients, we're going to begin with the initial resuscitation, where we are going to enforce nil per oral, where nothing is to be taken by mouth. You want to give IV fluids to correct the dehydration and electrolytes. You want to give the NG tube. We're going to put an NG tube to decompress and reduce the pressure. We want to put in a urinary catheter in order to monitor the urine output and make sure a patient is not oliguric. Then we want to do an analgesia and antibiotics. Also prospector if strangulated is suspected. Then we want to know what type of intestinal obstruction are we having, and that will help us determine the management. So if we have a simple intestinal obstruction where someone has got probably a stool for some time, but they are stable and there are no signs of strangulation, we are going to do the conservative management for at least 24 to 72 hours. And then if not, we shall go to surgery if we have no resolution. Then if we have a strangulated or a closed loop, we may need to do urgent resection, because a closed loop is deadly in a way that it is there's an obstruction proximally and distally, so it is very easy for things to get trapped in between there and there. The luminal pressure is going to increase very fast, and it will cause and it will lead to easy infection and strangulation. So it's better you treat that as an emergency and do an emergency laparotomy. Then we can have the function or the paralytic areas, and this can occur due to things like electrolytes, like hypokalemia, and these ones we may actually just need to treat the cause and support the patient as we wait recovery. So when we have a simple small bowel obstruction due to adhesions, we may do the conservative management, which is a drip and suck for 48 to 72 hours if there is no peritonitis in this patient. If it is strangulated, or we have closed loop, or we have peritonitis in this patient, you want to do an emergency laparotomy. If it is a large bowel obstruction like a tumor, you will need to do resection. For example, we have the Hartmann's procedure. If it is volvulus, and you want to do sigmoid endoscopic decompression, or you can do surgery if it is recurrent. If it is sickle, you may require to do surgical fixation and resection. Then in children into resuscitation, we may do a hydrostatic or the pneumatic productions. And if this fails, we can go to surgery. So we have the complications of intestinal obstruction, and these include strangulation and ischemia. They include perforation, sepsis, peritonitis, red bowel syndrome, as well as electrolyte imbalances. Then the indications for surgery in patients with intestinal obstruction: one, it may have signs of strangulation, that is continuous severe pain, fever, tachycardia, tenderness, leukocytosis, and metabolic acidosis. If they have peritonitis, if they have a closed loop obstruction, they have a complete large bowel obstruction, and if they have no improvement after 48 to 72 hours of conservative care. So we have come to the end of this video. We have looked at the causes, we have looked at pathophysiology, investigations, and management of intestinal obstruction, and I think this is some of the most important concepts when it comes to the management of this condition. See you next time in the next video. My name is Benjamin. This is Medman Preacher.